This 12th program in the video seminar series on echocardiography, presented by the American College of Cardiology and the Mayo Clinic, concentrate on three procedures: contrast echocardiography, echo-directed pericardiocentesis, and transesophageal echocardiography. Over the past 2 years, a number of individuals have contributed a great deal of time to the production of this 12-part series. Doctors Miller, Seward, and Tajik would like to thank their professional and paramedical colleagues. In particular, 5 individuals have played paramount roles: Mr. Phil McAteer in video communications, David Smirk for medical graphics and animation, Mr. Vernon Weber for echo and technical coordination, Charlene Tree for audiovisual and echo coordination, and Dr. Bill Edwards for pathologic specimens and tomographic correlations. The first technique to be discussed is contrast echocardiography and its clinical applications. We have purposefully avoided experimental applications. Many of these techniques do show clinical promise, but at this time are not being applied and thus are avoided in this particular presentation. 2 references are suggested, one from the Mayo Clinic from 1975 and is the first clinical application of contrast echo in M-mode echocardiography. The second is a comprehensive textbook on the subject by Meltzer and Roulant. A number of echo contrast agents have been utilized. These include saline, blood, indocyanine and green, radiographic contrast, which is usually sonicated, and some newer agents which are yet to be released. The procedures which follow utilize indocyanine and green, followed by a flush of saline. An inexpensive echo contrast agent is indocyanine and green. The technique utilizes a 3-way stopcock connected to the patient, a flushing port for the indocyanine and green, usually injected 1 or 2 cc's, followed by a flush of saline in the amount of approximately 5 cc's. Indocyanine and green is commonly used in a cardiac catheterization laboratory. The dose is usually 5 milligrams per cc. It is injected through the sidearm of the 3-way port, followed by a flush of saline. 2 assistants are required. This picture exemplifies the typical setup. The examiner, who sits at the right hand of the patient, observes the echocardiographic picture. 2 assistants are positioned at the patient's arm with the 3-way stopcock. Upon instruction, the indocyanine and green is injected, followed by the flush of saline. Within this discussion, we talk about the unique application of orthostatic contrast injections. Here with the patient in the upright position, contrast injected into the left antecubital vein. With the advent of color flow Doppler, clinical indications for contrast echocardiography have actually decreased. However, some applications still persist, such as the right-to-left shunts, particularly for orthodeoxia, which is a positional right-to-left shunt, patent foramen ovale, or special applications such as myocardial perfusion or during cardiac catheterization. This first example is of a patient studied for source of embolism with transesophageal echocardiography. This is a 4-chamber view. In real time, note that the valve of the fossa ovalis appears as a thin mobile membrane in the middle of the atrial septum. The right atrium, which will opacify first with a contrast echo, then goes into right ventricle, and no contrast is visualized in left atrium or in left ventricle. Upon repeating the injection, note that the right atrium and right ventricle opacify. However, in the area of the fossa ovalis, there is washout from the inferior vena cava blood. This should not be confused with shunt. As previously stated, contrast echocardiography is less frequently utilized in congenital heart disease today. However, one lesion, the left superior vena cava, either to the coronary sinus or left atrium, is an exception. This is an example of a 13-year-old boy with a left superior vena cava to the coronary sinus. This is a subcostal examination looking at the right atrium and right ventricle. Notice a dilated coronary sinus entering the right atrium. Following a left antecubital vein injection of indocyanine and green and saline, there will be opacification of the coronary sinus, confirming communication of the left upper extremity to the coronary sinus through a left superior vena cava. This boy had a ventricular septal defect, thus dye does appear in the left ventricle. Two lesions where contrast echocardiography is very helpful in the assessment of right to left shunt include orthodeoxia and pulmonary AV fistula. The next two examples are that of orthodeoxia, the first in a 49-year-old female who is breathless and dyspneic on exertion. In this apex up four-chamber view, the right-sided chambers are to your right. The first injection is with the patient recumbent, and the contrast will initially appear in right atrium and then into right ventricle. Note that there are occasional bubbles appearing in the left ventricle and left atrium, but there is no appreciable right to left shunt. These patients shunt in the standing position with injection into right atrium. Note that there is contrast into left atrium and left ventricle consistent with right to left shunting. This predominance of shunting in the upright position can be accentuated by a Valsalva maneuver. Here the patient strains, then injection into right atrium and right ventricle is followed by a more dramatic right to left shunt following the Valsalva release. The next is a dramatic example of orthodeoxia in a 64-year-old man post-pneumonectomy. The post-pneumonectomy patient is the typical syndrome in which there's predominant shunting in the upright position. Firstly, in the supine position, contrast enters the right atrium and right ventricle, and there is some contrast into the left-sided structures, indicative of a small amount of right to left shunting. Still in the supine position, note that the contrast enters right atrium, right ventricle, and then there is contrast entering from the left atrium into left ventricle consistent with shunt. In the standing position, there's a more dramatic right to left shunt. First, the contrast appears into right-sided chambers and then dramatically fills the left-sided chambers. Thus, in the standing position, there's a dramatic accentuation of the right to left shunt. That contrast injection is repeated. First the right-sided chambers and then the dramatic filling, first of the left atrium and then left ventricle, consistent with orthodeoxia, or right to left shunting with standing. Orthodeoxia should be suspected in any patient with inordinate standing desaturation. Contrast echocardiography is extremely sensitive in picking up pulmonary AV fistula. This is an example of a 55-year-old woman who is cyanotic. With the apex up four-chamber view, contrast will initially appear in the right atrium and right ventricle. Then after 4 or 5 cardiac cycles, contrast appears in the left-sided chambers. This is consistent with a pulmonary AV fistula. A second injection will again show opacification of the right atrium, followed by opacification of the right ventricle. Note the delay in appearance in the left atrium. This is consistent with transit through the pulmonary bed and a pulmonary AV fistula. Contrast echocardiography is extremely sensitive in picking up these right to left shunts and can localize them in anticipation of angiographic confirmation. An increasing application of contrast echocardiography is in conjunction with transesophageal echo. This is an example of a search for patent foramen ovale. This is an apex down, four-chamber view with transesophageal echo. Note that the foramen ovale appears as a thin membrane separating left and right atrium. With a Valsalva maneuver, note that the foramen ovale moves erratically and that with contrast injection, a marked opacification initially appears in right atrium and then left atrium, consistent with right to left shunt. This is a longitudinal transesophageal scan. The transducer is posterior to left atrium and right atrium, with the atrial septum and valve of the fossa vallis separating those two chambers. The ascending aorta is located anteriorly. Within the right atrium, the eustachian valve appears as an undulating membrane. The valve of the fossa vallis passes between the two atria beneath the ascending aorta. The ascending aorta is cut in oblique section, and a portion of the right pulmonary artery is posterior to the aorta. The superior vena cava enters this right atrium. Following injection of contrast, note that there is a negative contrast effect through the patent valve of the fossa ovalis. No right to left shunt was visualized. With a more magnified view of the valve of the fossa ovalis, patient is performing a Valsalva maneuver. Following contrast injection and release, note the transient right to left shunt across the patent foramen ovale into left atrium. This is an extremely sensitive echocardiographic technique for the detection of a patent foramen ovale. Over the past few years, contrast echocardiography is used less frequently for the detection of left-right shunt. However, with the advent of transesophageal echocardiography, contrast techniques have been used with increasing frequency. This is a longitudinal transesophageal scan in a 58-year-old male with a very small atrial septal defect. The atrial septum appears to be interrupted by a small defect. The defect is measured to be approximately 1 centimeter in diameter. The arrow is in the left atrium. With subsequent contrast injection, dye will initially appear in the right atrium through the superior vena cava. Note the negative contrast effect, confirming the small left to right shunt across this atrial septal defect. The next major procedure to be discussed is echo-directed pericardiocentesis. Two pertinent references include one by Callahan et al. In the American College of Cardiology discussing echo-guided pericardiocentesis in 117 patients. The second is by Kopetsky et al. And discusses percutaneous pericardial catheter drainage by echo technique. In Callahan's review of the literature of 341 patients undergoing blind pericardiocentesis, the complication rate was 12% and the mortality 6%. This led to the development of echo-directed pericardiocentesis. In a review of 450 patients, Seward et al. Found major complications in only 1% of patients, minor complications in 3%, and no mortality. Thus, echo-directed pericardiocentesis has become the technique of choice in this interesting application of echocardiography. There are 3 simple prerequisites to the echo-directed pericardiocentesis. Firstly, two-dimensional echocardiography is utilized to find that position on the chest wall where pericardial fluid is closest to the transducer. Secondly, two-dimensional echocardiography is utilized to determine the best entry point which avoids underlying vital structures. And thirdly, the site is marked prior to beginning the actual procedure. This still frame shows a large pericardial effusion around the apex of the heart, both anteriorly and completely off the apex. Note the large echo-free space which would totally avoid the underlying cart. This is better illustrated by turning the transducer at 90 degrees off the apex of the heart. Note that there is about 3 centimeters between the chest wall and the pericardial cavity and 9.5 centimeters of pure echo-free space which avoids all underlying structures. This is the ideal entry point. This slide illustrates the fallacy of using steel needles with electrocardiographic monitoring. This is a swinging heart. Note that upon entering the pericardial space, with the next cardiac cycle, the heart would literally impale itself upon the needle. To avoid this phenomenon, the echocardiogram would recognize the most appropriate space for entering at the apex of the heart, away from the vital structures such as heart, liver, or lung. In the Mayo Clinic series on echo-directed pericardiocentesis, the entry site was less commonly subcostal and more commonly chest wall. The anterior axillary line parasternal and midclavicular spaces were often utilized. Because ultrasound does not traverse air-filled lung and confidently avoids underlying vital structures, unconventional sites can be frequently or more commonly utilized. This is an example of a tray suitable for echo-directed pericardiocentesis. Multiple Teflon sheath needles are utilized, large syringe for withdrawing fluid, suitable tubing with three-way stopcock, scalpel, sterile 4x4s, steri-drape, multiple syringes, culture tube, and xylocaine anesthetic. Because the ideal entry site localizes pericardial fluid closest to the chest wall, 6 to 8 centimeter length, 16 gauge Teflon sheath needles can be utilized for the pericardiocentesis. If extended pericardial drainage is deemed necessary, a wire is inserted through the Teflon sheath. After withdrawal of the small sheath, a larger 7 or 8 French sheath is introduced into the pericardial sac. Through this sheath, a 60 centimeter pigtail catheter is inserted. Intermittent drainage is preferred. Intermittent installation of heparinized saline will keep the catheter patent. This will be an example of pericardiocentesis in a 50-year-old woman with metastatic breast carcinoma who presents with large pericardial effusion. The initial echocardiogram performed at bedside localizes the effusion, vital structures, and in particular, the point on the chest wall where the fluid is closest to the transducer. Note that in this particular transducer position, there's a small echo free space anteriorly. Similarly, in the short axis view, there's a larger space posteriorly, a small anteriorly located space. Certainly not an ideal position for the pericardiocentesis as the needle would enter close to the shifting heart. The M mode shows the swinging heart within the pericardial sac. A true apical view also shows that the apical impulse would be very close to any transducer entry site and thus would not be an ideal position or direction in which to pass a pericardiocentesis needle. This is the subcostal position. Note the large expanse of liver between the transducer and the pericardial space. This also, crossing over the liver capsule, would be a less than ideal position. Note that in this transducer position on the precordium, that a portion of the apex is still visualized. However, there is a large echo-free space medial. This is the ideal entry site for pericardiocentesis. Note that this site is selected by the examiner and then confirmed repetitively with the echo probe. An indelible marker is utilized to identify that position on the chest wall most suitable for entry. This places the pericardial fluid close to the chest wall. The examiner repeatedly determines the best angle of entry into the pericardial sac. The chest wall is then scrubbed with antiseptic solution and appropriately draped to begin the pericardiocentesis procedure. Remote echocardiographic examination can be performed. A sterile sheath covers the entry site. This particular woman has had bilateral mastectomies and is known to have metastatic carcinoma. The tap is primarily for diagnostic purposes to confirm the suspicion of metastatic carcinoma. Local anesthetic is instilled into the chest wall over an appropriately identified rib space. The fluid is actually close enough to the chest wall that the small probing needle will actually enter the pericardial sac through the anesthetized space on the chest wall. The larger 16 gauge needle is then passed over the rib space into the pericardial sac. Immediately upon entering the pericardial sac, the Teflon sheath is advanced and the steel needle withdrawn. Pericardial fluid pressure is obtained with manometry. In this case, a very low pressure of 5 to 6 centimeters of water. This patient was minimally symptomatic with a large pericardial fluid accumulation. A three-way stopcock and extender are attached to the needle. Fluid is withdrawn through the small Teflon sheath. Notice that the patient is comfortable and at ease throughout the examination. The fluid is collected into a vacuum bottle at the bedside. The withdrawal of fluid or position of the needle can be monitored by remote echocardiographic examination. Note, from the subcostal position, all of the pericardial fluid has now been cleared following this therapeutic pericardiocentesis. The Teflon sheath is then removed. The site will be covered with anesthetic solution and Band-Aid applied. This reasonably atraumatic procedure is well tolerated by almost every patient. Little anesthetic is required and very little risk to the patient, even with small accumulations of pericardial fluid. At the end of the examination, further echocardiographic confirmation can be obtained. Note the slowing of heart rate in this particular patient and the absence of any significant residual pericardial fluid. The second example is a pericardiocentesis in a symptomatic 50-year-old man who is in clinical cardiac tamponade. The pericardiocentesis is performed both for therapeutic as well as diagnostic reasons. Because of the clinical presentation of cardiac tamponade, it's deemed necessary that implantation of chronic pericardial drainage would be most prudent at this time. The most suitable entry site is identified on the left chest wall. This site is repeatedly identified, the angle of entry confirmed. An appropriate rib space is marked on repeated examination before the chest wall is then prepped with sterilizing solution. Remote echocardiographic examination can be performed at any time during the actual centesis procedure. The chest is appropriately draped. Note that the patient is allowed to assume the most comfortable position, but is then not allowed to move during the remainder of the examination. Because small needles are utilized, the patient usually can remain in a comfortable position and tolerate the procedure without further discomfort. Note that the site is marked clearly on the chest wall. Local anesthetic is infused into the superficial tissues of the chest and over the top of the appropriate rib through which the pericardiocentesis will be performed. The angle of entry is confirmed repeatedly. In fact, during local installation of anesthetic, frequently the pericardial sac is entered and confirmed. In the clinical setting of a large symptomatic pericardial fluid accumulation, protracted pericardial drainage was deemed necessary. Thus, the pericardial sheath was made ready, along with a short indwelling pericardial catheter. The pericardial sac is entered with a 16-gauge Teflon sheath needle. Note in this circumstance, the sheath is advanced atraumatically. A manometer reading of the pericardial pressure is obtained. In this example, the pericardial pressure is quite elevated, consistent with the symptomatic presentation. Note that the fluid level is in the range of 23 to 22 centimeters of water. Before any more fluid is drained, a wire is passed through the Teflon sheath into the pericardial sac. The small sheath is then removed, and the larger sheath is then slipped over the wire and then with a Seldinger technique advanced into the pericardial sac. This usually places the sheath in the posterior pericardial sac. In this particular example, an 8 French sheath was utilized, and a 60 centimeter 8 French pigtail catheter is to be introduced into the pericardial sac. Note that the pericardial fluid is bloody. You can confirm the position of either the needle or sheath with injection of blood, saline, or indocyanine and green. However, in this circumstance, the assurance of the introduction did not require further documentation of position. Using a 3-way stopcock system, the pericardial fluid is then drained by hand and collected in a receptacle at the bedside. At the end of the procedure, the introducing sheath is withdrawn and the side arm excised. Only the pigtail catheter remains within the pericardial sac. The site is then dressed like any other indwelling catheter system. Sterile solution, appropriate sterile drapes, and dressings are applied. A 3-way stopcock is attached to the catheter, and the catheter is intermittently filled with sterile heparinized saline to avoid clotting. The end of the catheter is conveniently covered with a sterile glove, which allows intermittent access to the 3-way stopcock without contaminating the remainder of the catheter. The catheter is then secured to the chest wall. The echocardiogram can be intermittently repeated to monitor cardiac function.